Hello, this is Nathan Radcliffe, and welcome to Interventional Mindset. I am here with a doctor who definitely has the interventional mindset, Dr. Paul Singh, cataract surgeon, refractive surgeon, glaucoma specialist, I think technological enthusiast, musician, and one of the best speakers I've encountered. And so I'm really happy to have you here, Paul.
Oh, thanks, Nate. I'm a confused glaucoma doc is really what I am. So thanks
Right.
for having me. Appreciate it, man.
Thank you. And so, part of what interventional mindset is all about is doctors kind of branching across, these categories from cataract to refractive, refractive to glaucoma, glaucoma to dry eye, all these different directions. And I think you embody that in so many different ways. And particularly tonight, I wanted to ask you about advanced technology IOLs. I do a little bit. I think I had the education to support their use, but I do find myself going into some of my days treating a ton of glaucoma and sort of drawing the line there. Like maybe I don't have something to bring the technology to the rest of my patients. And so, it's a Sunday night. What should I do tomorrow to kind of get more into this?
Well, I think the bottom line is what we're seeing now in eye care and ophthalmology and optometry in general is this new shift towards patient quality of life, patient satisfaction. And I think it's a perfect storm where everything is coming together at one time, right? We have this new emphasis on MIGS. And so now we're doing cataract surgery earlier. We're doing MIGS at the same time. So now people are off of drops. We're treating earlier, so we're having better chance of halting the progression when they're more mild. And so now we're also having better technologies, biometry, also toric lenses. So now we're able to have a better ability rather to help our patients who are suffering from glaucoma at the same time with quality of life as well. And so for instance, there are patients who are mild, who may be stable for years. They're on one or two drops. In the past, you'd say, well, if they have surgery, they're going to be back on drops. They're going to have dry eye. I'm scared to put a presbyopia correcting lens like a multifocal lens, which can cause glare and halos. Well, now if you get them off the drops, you treat them earlier. And if they've been stable, mild glaucoma, let's say the central 10 degrees is still healthy, they're maybe pre-parametric and stable, that might be a good candidate still to help them, give them opportunity to be spectacle independent. And so I think it's really picking the right patient, realizing now we have the technology with these new quadrifocal lenses like the Panoptics. We're seeing contrast technically can be a little lower than, let's say, a monofocal lens, but it's still the light scattering is less and there's more light entering the eye than some of the previous iterations of multifocality. So also we have EDOF lenses, those range of lenses that help with distance intermediate that also maintain pretty high contrast sensitivity, and monofocal lenses such as, let's say, accommodating lenses like the crystal lens and others. So we have opportunities to help our patients be spectacle independent, whether distance intermediate or distance and reading, if we pick the right patients. And now because of MIGS and because we're earlier, I think, addressing a lot of the compliance issues, we can halt the progression earlier when they still have healthy fields and healthy ganglion cells.
And so I imagine you must have patients where you just have a ton going on. They're on some drops, you're going to do some MIGS, you're going to put one of these lenses in. Is it ever overwhelming? Maybe you're going to use some Dextenza or Dexecue, or does it just get to the point where you're used to doing all these things on as many patients as you can?
I don't, that's a great question, Nate. I don't try to look at him as a completely different patient. I look at it as a patient who wants to be spectacle independent. And like anybody else, let's say you're not a glaucoma patient. If you have an ocular surface that looks like crap, I'm going to treat your ocular surface first. If you have an angle alpha that's pretty large, let's say 0.7, I'm not going to put a multifocal lens in there because, of course, risk of glare and halos. And so for me, it's just like looking at this as any other patient. I want to maximize quality of vision, quality of life for them. So for instance, I think toric lenses. So if you're a doctor out there and you're like, look, I do glaucoma, I'm not really into premium lenses right now, the best way to start is just start with a toric lens. We have a lot of lenses out there, and now with some lenses which even have lower toric powers, like a 125. So if you have an against the rule astigmatism, 0.75 less than diopter against the rule, why not take care of that at the same time? Help maximize the quality of the light entering the eye to help them with the quality of vision. Because we do know that glaucoma patients lose contrast sensitivity. It's one of the earliest findings of glaucoma. So if we can maximize the light entering the eye with a toric lens, even better. And so it's at first that philosophy of let's treat these patients like any one of our other patients who deserves the best quality of vision and also the best quality of life. And that balance of whether it's multifocal, accommodating, or toric lens, it just depends on the risk factors. So glaucoma is another risk factor for a multifocal lens, just like a high angle alpha is or a dry eye. Glaucoma is another one. So now if I have a moderate glaucoma, they're not controlled, they're on 3 or 4 medications, they're probably going to be on medications afterwards, I wouldn't do it. It's not worth it. But if there's a stable patient, ocular hypertensive, POAG has been stable on a prostaglandin for years, you can do your stent, cataract combo, whatever you do, and you're happy with that. Their 10-2 looks pretty good. Their ganglion cell layer looks pretty good on OCT. Why not try and give them an opportunity? So just like any other risk factor, I take glaucoma as another risk factor for me to decide if they can handle a multifocal lens.
So I'll make 2 comments. One is that I've never seen a glaucoma patient who had a multifocal IOL and one was unhappy, who wouldn't have been unhappy with a monofocal IOL, which is to say, I always say anyone who has foveal loss from glaucoma is unhappy no matter what lens is in their eye. And,
True.
and so, I tend to think, and I see many happy patients who have glaucoma and multifocal IOLs. So I want to get your thoughts on that. And then the other question is, I'll talk to my refractive colleagues and they'll say, well, I can always do LASIK. If I do a multifocal IOL and I miss the target, I'll just tune them up with a little LASIK. And that's where, as a glaucoma specialist, I start being less comfortable. Is that an option? Do you ever do that? And then, I'm curious to hear what you think about, the sort of unhappy glaucoma patient with the multifocal.
No, good point. I mean, if you think about it, how many patients of ours who are phakic and have a cataract who are living life with decreased contrast and they have glaucoma, right? We don't even think twice about a 2+ NS cataract or 20/30 vision. We're like, see you later, come back in a year. But they have decreased contrast because of the cataract. So you put a multifocal lens in, let's say that has decreased contrast slightly, of course, let's say PanOptics or some of those other ones where there's some decrease, no doubt, but it may not be as significant as some of the predecessors of multifocality. How worse are they, right? And that's the question that we have to ask ourselves. So I think you have to judge the patient, judge this potential for them to progress, judge their disease state at the time of doing surgery and a history. And of course, we all know the patient, personality. If the personality is such that they're going to be kind of worried about every little glare and halo issue they might have, again, like anything else, we want to make sure we judge the right character for that lens. To answer your question about post-op, if they're not happy, I do think if there's a glaucoma patient, if they're not happy, you could always do a lens exchange if you had to, which is not ideal. But I do think PRK is safe for some of if you pick in the patient who's mild to moderate glaucoma, more mild rather, and they're stable, if you had to do a PRK enhancement, let's say, hypothetically, and if you don't do it yourself, you can send it to a colleague who does it. I think the relative risk of a PRK in a patient with glaucoma who's otherwise stable, I think is relatively low compared to some of the other risks that we do in general. So I think you have to be aware of that, but I'm comfortable performing a PRK for, let's say, a -1, or let's say you have some cylinder left over. I'm not afraid to do that on a patient if they have glaucoma. Usually their pachymetry is healthy enough and you know kind of where their pressures are at. And the risk of them, let's say, having a different pressure postoperatively to measure afterwards is fairly insignificant compared to other issues that we face in glaucoma.
Right. I appreciate all these thoughts. And as I was saying, the interventional mindset is, you sort of embody it. I wonder if you might share a case or 2 with us at some point in time. We're always happy to hear from you. Any final thoughts for us on bringing these technologies into the practice?
Yeah, I think it's just, again, I think we're seeing with interventional mindset, whether it's drug delivery, whether it's laser trabeculoplasty, whether it's other MIGS procedures, we realize now that we have to address patient satisfaction and compliance. And patient satisfaction now, I think we're rolling into, well, why not give them the best quality of their life if for them, they really do want to have spectacle independence as much as possible. It might be, I use a lot of accommodating lenses like the crystal lens, or I use an EDOF lens or a PanOptics. Everybody's different. There's no right answer. Kind of like MIGS, there's a different MIGS procedure for the right patient. So just think about it. I think being aware that these patients deserve it now as well. And our surgeries, we have better controlled outcomes now. Unlike a trabeculectomy where we could cause cylinder, we're having stitches in the eye, recovery was very long. Now, because our MIGS procedures are much, I think, more controlled postoperatively, and we can actually have more predictable outcomes, we now can start to measure and be more predictable with our lenses as well. So just think about it, try it. I think toric lenses are a great way to start, and you'd be amazed at how happy these patients are. In fact, I'm going to share with you right now a quick case. We'll check it out. Here we go. All right, well, here's a patient with POAG where I did implant a multifocal presbyopia correcting lens. Patient who's a 69-year-old lady with 20/40 best corrected vision, mild, -6 with a little bit of very little astigmatism with the rule, middle to upper teens on PGA and a combination medication, but really healthy and stable fields for years. Healthy RNFL and GCC also stable for years. Angle alpha 0.3. Angle alpha, again, is the difference between the center of the limbus and the center of the visual axis. In other words, if it's like 0.5 or 0.6 or higher, there might be misalignment and you might have higher risk of vision complaints post-operatively. Hysteresis was also fairly normal with a healthy pachymetry, and HOA of the cornea using the eye trace was also fairly healthy. So I felt pretty good about this patient's quality of vision in general with the cornea. GCC looked overall fairly healthy, a little bit of some loss maybe inferiorly there, but fairly healthy in the most part. And the RNFL looked pretty good as well and had been stable. Again, this is a snapshot, but over the last few years has not changed. Larger discs as well, which could account for the larger cupping. But the fields look pretty good. The left and right eye look pretty healthy. I did do a 10-2. I didn't show it here, but 10-2 also looked healthy. I think it's important to sometimes do a 10-2, even if the 24-2 looks healthy. You never know what's going on in that fovea, and you may be surprised sometimes picking up some decreased sensitivity as well. But fairly healthy fields that have been stable over the last few years. So I feel pretty good about implanting a hydrus with a Panoptix. I actually also did the combination with a Omni here. So I did a viscodilation combining different mechanisms of MIGS procedures where I can dilate the Schlemm's canal with this catheter. It releases viscodilation, viscoelastic into the Schlemm's canal. And now I'm going to go to the same opening with my hydrus loader here, and through the same opening, just implant the hydrus. Goes right into the same area where I did my viscodilation using the Omni device. And again, slides in beautifully like butter. And you see how nicely positioned that hydrus is as well. And so I think this is a good combination of viscodilating the Schlemm's canal and the distal channels, and then placing the stent there. And I just think it's always fun to show eye candy when you are removing viscoelastic and then you have your INA in there. You can just see the nice fluid wave showing you increased outflow facility in that area. But again, this is a good way to kind of get the patient off of medications. Combining, for me at least, the viscodilation and the stenting has helped me decrease the drop burden for these patients as well. And so this is a patient I feel very confident. You can see here pre and post kind of the venous blanching, venous system and the episclera there, showing nice blanching post hydrus and viscodilation. And now I'm just going to go ahead and make sure my multifocal lens is centered, which looks beautifully. I use a Callisto overlay for this to make sure everything's stable. But again, I think it's a great candidate. Very healthy eye otherwise. Just to give an example of a patient where I did actually a crystal lens and an eye stent. I do a lot of crystal lens as well for those patients maybe who have unhealthy corneas, dry eye, macular issues. Glaucoma, again, we talked about losing contrast. Well, if someone does have more moderate glaucoma, or I feel like maybe progressing, I don't want to take a chance at a multifocal lens, I'll do also, I perform a lot of times a crystal lens implant, one of the accommodating lenses, where I don't have to have the risk of a multifocal lens losing contrast. And placing my 2 eye stent injects here, beautiful position, about 2 clock hours away. The reflux of blood is very common and very normal. And removing my viscoelastic here with my crystal lens in beautiful position, centered nicely. See that nice blanching, that arrow is showing, again, the eye candy that we love to see. Nice blanching before and after picture. You can see the venous architecture, the blood vessels there, pre on the left and post on the right, showing you can see blanching very nicely. And always like to make sure that the eye is pressurized at the end of these cases to prevent reflux of blood. Also with the crystal lens, keeping it nicely posterior vaulted as well. But again, those are just a couple cases. Hopefully it'll help to kind of clarify my mindset of how I decide what to do.
Paul, I love that case. Love watching you operate. Everything always looks so good. You make it look easy. And thank you for sharing your thoughts and opinions. We all really appreciate learning from you. And on behalf of Interventional Mindset, thanks for your help tonight.
Thanks a lot, my friend. Take care of yourself. Appreciate it.
Be well.